Picture this. You're in the OR. There's a flurry of activity, but it's all controlled, focused. Every beep from the monitors, every sharp command from the surgeon, it's all part of a desperate race against time. And the enemy here isn't just the obvious injury. It's something far more dangerous, the rapid loss of the body's most critical resource. So what actually happens when that vital fluid, blood, starts to run out? When the very river of life that carries oxygen to every single cell starts to drain away, it kicks off a catastrophic chain reaction. Today, we're diving deep into hemorrhagic shock. All right, so to really get a handle on how to fight this thing, we first have to understand the devastating domino effect it creates inside the body. It is a relentless, predictable sequence of events where each step knocks over the next. Okay, so here's the official definition. But let's break that down. The key thing to understand is that hemorrhagic shock isn't just bleeding a lot. It's about what happens because of the bleeding. The entire circulatory system fails to deliver enough oxygen to the body's tissues. On a cellular level, the body begins to starve. Think of it like this. Your circulatory system is a city's water supply, and your heart is the main pump. If a giant water main suddenly bursts, that's your rapid blood loss. The volume in the system just plummets, right? So less water makes it back to the pump, which means the pump has less water to send out. Pretty soon, the homes at the very edge of the city, our tissues or organs, they just run dry. And that right there is shock. And you know, this isn't just about the dramatic trauma you see in movies. As you can see, this is a threat that looms everywhere in medicine. In the operating room, during childbirth, or even from something happening deep inside the body, like a ruptured aneurysm. It's a common enemy that spans so many different specialties. But here's what's so fascinating. The body is incredibly smart. In the beginning, it kicks into survival mode. It starts clamping down blood vessels to your skin, your arms, your legs, basically redirecting every last drop of oxygenated blood it can to the most important places, your brain and your heart. And this is why the early signs can be so tricky to spot. The body is literally hiding the problem while it tries to fix it. But that compensation can only last for so long. If the bleeding doesn't stop, the body falls into this terrifying, self-perpetuating downward spiral. In the medical world, we call this the lethal triad. And this diagram just perfectly captures that vicious cycle. You see, the blood loss is what kicks the whole thing off. But it's these three components, acidosis, hypothermia, and coagulopathy, that create a feedback loop that is incredibly hard to escape from. Each problem makes the others worse, and it just accelerates the patient's decline. First up, acidosis. Okay, so your cells are starved of oxygen. They switch to this, let's call it emergency backup power. But this backup generator produces a nasty byproduct, lactic acid. The acid builds up in the blood, making it more acidic. And that acidic environment is toxic to the very enzymes your body needs to form a clot. They stop working properly. Second, hypothermia. The patient gets cold, not just because they're exposed on a gurney, but because they're losing liters of warm blood. Well, guess what? Those critical clotting enzymes we just talked about, they are super sensitive to temperature. Think of them like tiny biological machines that literally start to freeze up and seize when they get too cold. They just stop working. And all of that leads us right here, coagulopathy. It's a fancy word for when the body just can't form clots anymore. It's caused directly by the acidosis and the hypothermia, and to make matters worse, it's fueled by giving a patient IV fluids that dilute whatever little clotting factors they have left. So what happens? The patient bleeds more, which makes them colder, which makes them more acidotic. And there it is. That's the cycle. And this brings us to a really, really crucial clinical warning. Sometimes a well-intentioned action can have devastating results. Pumping a patient full of cold IV fluids to try and get their blood pressure up can actually pour gasoline on this fire. It can supercharge the lethal triad, making the patient colder, more diluted, and even less able to clot. Okay, so we get the what and the why. Now let's switch gears. How do clinicians on the front lines actually read the signs and figure this out in the middle of a chaotic, high-pressure situation? This comparison right here is absolutely key. In that early, compensated stage, the body's fighting back. The heart rate is up, the patient feels anxious, but look, their blood pressure might be totally normal. A low blood pressure, hypotension, that's a late sign. It means the body's defenses are already starting to crumble. So, clinicians use this framework, the ATLS classification, to stage the severity. Now, look closely at this. You can lose up to 30% of your entire blood volume. That puts you in class 2 shock, and your blood pressure can still read as normal. It's not until you get to class 3 that the BP consistently starts to drop. So, if you can't always trust the blood pressure early on, what can you trust? Well, there's this incredibly simple but powerful tool called the shock index. All you do is divide the heart rate by the systolic blood pressure. A normal person's is around 0.5 to 0.7. As that number starts creeping up towards 1.0 or higher, that's a massive red flag that your patient is in serious trouble, even if their blood pressure looks okay. So here's the big takeaway for this section. Trust the tachycardia. Trust the fast heart rate. That is the body's first and most reliable alarm bell. The blood pressure is a latecomer to the party, and by the time it shows up, things are already critical. Okay, so knowing everything we know now, let's look at the actual playbook. How do medical teams jump in and stop this cascade to save a life? It all really boils down to this elegantly simple principle right here. 2 goals, and the order is absolutely everything. First, you stop the leak. Then, and only then, do you worry about refilling the tank. And here's how that principle looks in action. Number 1, hemorrhage control, whatever it takes. 2, notice it says restrictive fluid resuscitation. The goal is a blood pressure that's just good enough, not perfect. This is to avoid fueling that lethal triad. 3, you have to actively warm the patient. And 4, you give back exactly what they lost, blood products, in a balanced 1-to-1-to-1 ratio. Now this is brilliant. How a patient responds to just a small initial amount of fluid is a huge diagnostic clue. If they get better and they stay better, great, the bleeding is probably stopped. If they get better for a minute and then crash again, a transient response, the leak is still active. That patient needs blood and an operating room right now. And if there's no response at all, that is an absolute catastrophe. So as we wrap this up, after all the physiology, the diagnosis, the treatment, in the middle of all that chaos, with alarms blaring and the pressure on, what is the single most important concept that you cannot afford to forget? It all comes back to this, the lethal triad. Every action you take, every decision you make has to be laser focused on preventing or breaking the cycle. Warming the fluids, giving blood early, getting to the OR fast. It's all designed to stop this deadly feedback loop. It's about constantly asking yourself, is my patient getting colder, more acidotic, less able to clot? That is how you break the cycle. That is how you save a life.